Is the screen visible to everyone?
Yes.
Okay. Okay, Shani. This case is for you. This
Okay.
is, this is a 48-year-old man presented to ED with fatigue only.
Presented to ED with
Fatigue.
fatigue. Okay.
Yeah. So the blood test shows hemoglobin of 130, white cell count of 31, and platelets of 180. The
Okay.
BMS did a blood thin and it shows some abnormal cells.
Okay.
So this is a 50 power because the slides are oiled, so I cannot go to 20.
Okay.
So I
Can
will,
you move around?
yes, so I will move around.
Anyways, here I can show, and here I can see monomorphic lymphoid cells, and
I
their
have, I have 100 power as well. Whenever you want, I
no, no,
can.
no, no, it's okay. I don't need 100. Um, there is increase these lymphoid, mature looking lymphoid cells. These have high NC ratio, but there are cells which with the immature chromatin and prominent nucleoli. So I can
Okay.
see the neutrophil platelet count is looking normal.
Yeah.
Neutrophils are
So
present.
I will take you through the exam style.
Okay,
First, I'm moving around here and there, and
okay,
then my question to you would be for a 5 marks or 6 marks. Report the
o-
blood film.
okay,
I do not expect a diagnosis in this film. I just need a report. I will
okay.
take you to the blood film. I will show you in a high power as well. Uh, Now you can report the blood film.
Yeah, the red cells are mostly normochromic and normocytic, but I can appreciate two populations. Some are like with normal, some are completely filled, but others are normal. I don't know whether these are the transfused or not, but there is increased population of lymphoid cells. Most of them are monomorphic and mature looking, but some of the cells are bit larger and having a prominent nucleoli like these cells. Platelet appear within like platelets are normal and unremarkable. Can you move around for the
Okay, we'll go back to 50.
yeah? There are the neutrophils present.
Dr. Amir, I can also see some stereocytes. Is it- Or is it some artifact?
And smear cells are also present. Smear cells and mature looking lymphoid cells, normocytic, normochromic red cells. There are some, I don't know, spherocytes or completely filled red cells.
Dr. Shaheen, I
Yeah.
think there is some indentation in some of the lymphoid cells as well.
Yeah, I can see there is indentation, but when the Amal was on high power, then I can't see the indentation. Mm, I couldn't. I was not like convinced with the follicular sort of. The indentation is through and through in follicular. Most of the cells are like small, mature-looking lymphoid cells. There is smear cells, and here this is there's a cleaving is present in some of the cells, but not all. Again, there's a cleaving of the cells. Nuclear cleaving is present in some of the cells.
Okay. So now, how would you write in the exam to report the blood film?
In exam, we should comment on all three cell lines, red cell, platelet, and white cells, or any other abnormal cells, or any other abnormal feature. And I guess in reporting, these are the main features.
So that's what I'm asking you. You are sitting in a FRC Part 2 exam. This is the
Yeah,
blood film for you. There is a
yeah,
5 or 6 mark question.
yeah.
The question is asking you, please report the blood film. The patient has come to A&E with persistent fatigue, and his white cell count is 31, platelet is 181, and hemoglobin is 130. This is the blood film. Report the blood film.
Okay. Um,
Just 1 minute. Dr. Amara is waiting in the waiting room. Can you please add her?
Amara is not here
You guys can add because I cannot see.
because I can't see. Amara is here. I can see.
I think everybody can admit the guest in this.
Yes, admit any.
Yeah, I have admitted 2 people before, so it's I think everybody is here.
Okay, okay.
Okay. Coming back to the question,
Yeah.
report the blood film.
In reporting, the red cells are normocytic, normochromic. There are few, I can appreciate few spherocytes, but otherwise it's normocytic, normochromic. There is increased population of lymphoid cells, which are having a high NC ratio and somewhat mature chromatin, but some of the cells have prominent nucleoli. And I can appreciate the neutrophils and platelet count is appear normal on the slides. And there are Smear cells also noted.
You start with the blood film shows lymphocytosis or mature lymphocytosis.
Okay, okay, okay.
But lymphocytosis is the main feature in this blood film.
Yeah.
Then, because you are addressing the doctors, the hematology people now, because this patient is an A&E, you are not addressing a GP. Then you can a little bit describe that the nucleus is mature, some have leaves with clear cytoplasm. The
Okay.
platelets are fine, there are two smear cells, and the red cell morphology is okay.
Okay.
Now, this is half of your report. What is your impression?
It is my impression is like it's lymphoproliferative disorder, and probably it is chronic lymphocytic leukemia. But I would like to rule out.
I asked you, I do not expect a diagnosis from you.
Okay.
I have not given you any flow cytometry or
Yeah.
So you were correct. You're saying that this is a lymphoproliferative disorder. So
Okay.
the blood film is consistent with most likely with lymphoproliferative disorder.
Okay.
Okay. Now still your report is not complete. You need to suggest something.
So in suggestion, I would like to do flow cytometry immunophenotyping.
Mhm.
Or
Yeah. So you would recommend that this patient needs further testing, like blood for immunophenotyping, to find out the lineage
okay.
of the disorder. So now your blood film reporting is complete.
Okay.
Yeah. So now uh, in the question, they may have given you immunophenotype. So you can figure out which type of lymphoproliferative disease is this.
Okay.
But now the next question can be, what are the differential diagnoses here?
Okay.
So what will be your differential diagnosis?
My differential diagnosis is for LPD is CLL, chronic lymphocytic leukemia. It could be a small cell variant of a mantle cell, or it could be follicular as well. I want to rule out follicular as well.
Okay, so you have given the differential of mature lymphocytosis.
Yeah.
That's correct. So now you have 5 marks of blood report, 2 marks of differential diagnosis. You have 3 marks remaining. So how will you manage this patient?
Yeah.
How
Do
will you
I would like to check for in indication for CLL management, if there is an indication for treatment, because count is 31,
you don't
hemoglobin is 13.
you don't know that this is CLL.
Okay.
This patient is an A&E. You have the blood film. They're asking you how would you manage this patient. Consider this is a real patient. You are a hematology registrar on call,
Yeah.
and you have a lymphocytosis now. What would you do now? Patient is with fatigue in the A&E.
For hematological, as hematologically, I would not treat the patient at 30,000 count. I would see whether the patient what is the stage of the disease, what are the other parameters. Is there any lymphadenopathy, bulky hepatosplenomegaly? Because at 30, I would not treat the patient.
You are not treating the patient. You are still to diagnose the patient.
Then
Dr. Amir, we will do other testing, LFDs, RFDs, electrolytes,
I would check
any signs of
In the
tumor lysis.
management, if they ask about the management, can we start from the history that clinically I will go for the few points and then I'll go further?
You will take history from the patient. You will do relevant clinical
examination.
for
Exactly.
of the patient. You will send the blood for flow cytometry in this
Yeah.
patient. If you have any B symptoms in this patient. He mentioned only fatigue. Upon a history or examination, if there is any B features in this patient, then you may admit the patient and go for imaging as well.
So in management, we start from the history. We ask for the B symptoms: weight loss,
Yes.
fever, night sweat.
Because this is for 3 marks.
Okay.
Assessment of the
Okay.
patient, investigations. In just a number 8, you cannot write a big lines in the morphology section for 3 marks. So assessment of the patient and investigations of the patient.
Okay.
And
Okay.
if there is any indication in this patient, like uh, organomegalies or B symptoms, then you need to admit the patient to decide
Okay.
whether you need to treat this
Can,
patient or.
can we start allopurinol?
His count is 30 only.
We will not start.
No.
So
Count
if in management, so we can write, we have to ask for the history relevant to the whatever the if it's a high grade B symptoms, or if it's a low grade lymphoma, like if it's a GI something. I'm just in general asking. In management, we have to include point about the history, then we have to include the point about the staging and the prognostic factors, isn't it?
Yes, but in
And
points, because this is for 3 marks only.
okay.
Yes. Now, for example, this is the blood film, and they have given you a flow cytometry which says this is CD5 positive, 19 positive, 10 negative, 20 positive,
Yeah.
and 200 negative.
Yeah.
Then do you have a diagnosis now? Then they can ask a diagnosis to, because they have given you already a phenotype.
Yeah, CD5 positive and 200 negative and 10
200
negative.
negative, 19 positive, and 20 positive.
Yeah. Can you,
So what is the diagnosis now? I have given you the phenotype.
if it's 200 negative and is
5
it
positive.
mental?
It could be
Mental.
mental with
Mental.
the 200 negative, yeah.
Yeah.
Mental.
Because 23, you didn't tell 23, and it could be
200.
mental. Hmm.
Because the 5 positive, 10 negative, and 200 negative, it could be mental because CLL will be ruled out.
Yeah.
Hmm.
Yeah. So there are 2 differentials for CD5 positive, MCL and CLL.
Yeah.
I mentioned 200 negative.
Hmm.
If you have asked me what about 23, I would have told
Yeah.
you that it is negative as well.
It is negative. Then it's CLL is rule out. It is mental. Then what about the cyclin D1 and
Yeah,
or
cycle 0 is positive, or SOX11 is positive.
SOX11 and cyclin D1 is positive. Then it's mental.
Mental, yeah. So this much will be asked from you in a morphology question. They would not ask about treatment or
Okay.
trial or anything else. Just these questions. Report the blood film. What are the differentials? What investigations you will do next? What is the initial management? These
Okay.
3 or 4 questions will be asked in morphology. And let's make a good report. They do not expect a diagnosis from you in the reporting side, because you do not have a phenotype or cytogenetic.
Yeah.
Unless I told you about the immunophenotype of this case, you cannot make a diagnosis.
Yeah.
So report contain explanation of the blood film, your impression, and suggestion of next step. These 3 components make the blood film or aspirate or refine report. They will give you marks for that.
Okay. Thank you for your input.
This was the first one. Who want to go next? Any volunteers? Amara, I would pick on you.
So this is a slide.
So this is a spot diagnosis.
Just spot diagnosis, filariasis.
Report the blood film, and for 6 marks and 4 marks, what is the management of the patient?
So, do we have to explain the slide or we just do the spot diagnosis?
Like you have report the blood film, just like any blood film you report, you just report the blood film.
Okay. So from here I can see RBCs are normochromic, normocytic, increased platelet count, and there is I can see neutrophils, and I can see Trypanosoma cruzi with prominent nuclei, and at posterior edge there is a kinetoplast and a flagell. It's a and the flagellum.
So you're describing the trypanosoma, so we make it 100 film.
Yes. So at interior end there is a flagellum, and in the middle there is long nucleus, and posterior end has kinetoplast, and it is
So this one is clear. They do not expect this much detail from you.
okay.
Yeah. So you have identified trypanosoma.
Yeah.
Comment on the red blood cells, white blood cells, and platelets.
Mm.
That's it. And they would not expect whether this is trypanosoma cruzi or brucei.
Okay.
You have seen the trypanosoma, and that's it.
That's it.
Yeah. So now you have commented on the blood film. Your impression is consistent with trypanosomal infection and suggestion now.
Suggestion for further testing?
Yeah, you have commented on blood film. You have got the diagnosis. What would you write on the suggestion section of the blood film?
Suggestion is this blood film is suggestive of trypanosoma, and further testing can be done by trypanosoma antibodies to confirm the diagnosis. Antibodies can be done, or do I have to evaluate the patient? Sorry? Do I have to do other investigation like chest X-ray or anything if the patient has symptoms?
You will not write these things in the blood film report.
That's it. So we can confirm the diagnosis by serology testing or antibody testing against trypanosoma.
Confirmation and type of trypanosoma species is needed by RCI lab. Sorry, reference lab, not RCI.
Reference lab.
Yes. Then in management section, how would you manage this case?
I think it was no. I don't remember, albendazole or benzinidazole?
If you write albendazole, no one will give you 4 marks. So you have to refer the patient to infectious disease.
Mm-hmm.
Drug of choice is pentamidine after consultation with infectious disease,
Mm-hmm.
and sending samples to reference lab for confirmation.
Okay. Drug of
So
choice is pentamidine.
pentamidine for trypanosoma, I think. It's not albendazole or mebendazole.
Mm-hmm. Or is it enough to write, I will refer it to for the reference lab and to infectious
Yes, because you cannot do anything else for infectious disease patient.
so I will refer to infectious disease.
They have
Or
to
do
be
we have
treated
to write?
by they have to be treated by the infectious disease people. So refer
Okay.
to infectious disease lab, sending samples to the reference lab, and for more marks or good impression, you can write drug of choice is pentamidine for trypanosomiasis
Okay.
or nifurtimox, something like that. I checked that in the CDA parasitology. They mention, I think, pentamidine and nifurtimox and besnidazole, something like that.
Benznidazole.
All right. Make a habit of blood film, aspirate, or refine reporting. You may be knowing the diagnosis, but diagnosis carries only 2 marks. If you do not write a good blood film report, you will lose a lot of marks. You may fail the question even if you know the diagnosis. So in the exam, the half of the marks is for reporting the blood film or aspirate or refine. Who is next? Who's volunteer? Sana.
Hello?
Yeah.
Ji.
Can you hear me?
Yeah, I can hear you.
Okay. So this is a 50-year-old patient presented to ED with shortness of breath. Upon chest X-ray, there is a pleural effusion in this patient. The full blood count shows hemoglobin of 101, white cell count of 73, platelet counts of 150. This is the blood film.
So I will start from the RBC. So there is the hypochromic normocytic
You
RBCs.
cannot start from RBC because the main feature is lymphocytosis. Sorry,
Lymphocytosis. Yeah.
high white cell count.
Okay.
So the blood film shows blah blah blah.
Okay. So there is the marked lymphocytosis. The the lymphocyte seems to be mature and with the dense chromatin, and there are few cells with the few smudge cells can be seen, and so there's a mature lymphocytes count. Count is raised on the film, and few lymphocytes with the blebs, cytoplasmic blebs, and the platelet count seems normal, a bit decreased. So
Oh, so what is your impression?
so it's mature lymphocytosis with the blebs, cytoplasmic blebs. So it's with a circumferential.
Okay.
It's a marginal zone, maybe. I'm not sure about it.
Yes. So this is mature lymphocytosis, and there are cytoplasmic blebs.
Yeah.
There is pleural effusion as well, and white cell count is very high as well. Proliferative disease. What would you suggest on the blood film? What to do next?
So I will ask for the immuno of that patient. I will suggest the investigation for the immunophenotyping and the flow for that patient.
Okay. Right. So next question can be, what is the expected immunophenotype in this case?
Could be CD.
So do you have any diagnosis in your mind?
It looks like to me the marginal zone, splenic marginal zone could be in DD. I'm not sure about it, because there could be some circumferential cytoplasmic blebs are there. I would not go for hairy as the count doesn't favor for that. So CD, maybe CD27, 103, CD123, they could like help to go towards the diagnosis.
So expected immunophenotype in this case is CD2 positive, 5 positive,
These.
7
Okay.
positive as well, and 52 positive. Let's say the scenario says the flow cytometry shows 2 positive, 5 positive, 7 positive, and 52 positive.
Then it could be the TPLL, maybe. Not TPLL.
Okay.
Yeah.
So you have reported the blood film, and you have answered the question, what is the expected likely diagnosis in this case, 2 marks. The next question would be, what cytogenetics are involved in this case? 2 marks.
Cytogenetic. No, I sorry, I don't exactly remember the cytogenetics in exit in this case.
Okay, so 14-14 translocation is the
Okay.
involved cytogenetics here. This question was also for 2 marks. The last 2 marks are what are the first line treatment option in this case?
I think it's CD52. If positive, then alemtuzumab can be given in that.
Okay, all right. Yeah, so this is a T prolymphocytic leukemia, TPLL, the blebby leukemia. You mentioned that the nucleus is mature, cytoplasm is empty, blebby. Patient has pleural effusion. TPLL patient usually comes with either splenomegaly or pleural effusion or ascites with high white cell count, and flow cytometry shows T cell markers are there.
Okay.
So the question would be to report the blood film. TPLL was a question in the autumn 2023. So we're going for autumn 2024. This can be an expected question.
Excuse me,
So-
anybody can see Noha or Sandhu because I cannot see them and I cannot admit them.
Okay.
They're messaging.
Okay.
I cannot see them in like.
Yeah, I cannot see them both. Sindhu and
Dr. Amir, I have a question. If I have got such kind of morpho and there's no cytogen, no immunophenotype, so is that easy to pick? Either it's a TLL or it's a BLL, TPLL, or it's like lymphoma.
So TPLL has a typical blebby cytoplasm. You mentioned markers on lymphoma. They don't have that type of blebby cytoplasm, and those cells are plasmacytoid type of cells. These are not plasmacytoid cells.
Okay, B cell lymphoma, you said it's a plasmacytoid cell. The TR like
marginal zone lymphoma, I was saying.
Yeah,
Because
because
you
confused
mentioned
with the
marginal
marginal
lymphoma.
zone in that. Yeah.
Sorry?
I was confused with the marginal zone in that because I couldn't recognize on morpho either it's a marginal RT.
No, marginal zone lymphoma would not have this type of lymphocytes. They have
Okay.
plasmacytoid type of lymphocytes and not big blebs like these cells have. They have
Okay.
small hairy like projections, and the white cell count is not that high in marginal zone lymphoma.
Okay, that is the big point as well. Okay.
So practice reporting TPLL like in writing, because the paper informs you should have a writing practice, cytogenetics, expected immunophenotype, and treatment, because it's very straightforward treatment for TPLL. Either white plate, if asymptomatic, if symptomatic, then empath.
Thank you, Dr. Amir, for the nice case. I have Dr. Amir, if they ask for the morphology, and in the morphology section we divide in 3 portions like description, impression, and suggestion. If
Yes.
in impression you couldn't tell about the, like in impression mostly you could be towards the diagnosis. If that impression is wrong, so all the morphology will be like there will be no number for the morphology if there is impression is wrong for that.
No, it is just an impression. You will do further testing
Okay.
to make a diagnosis. Sometimes we think this is a CLL case, but once the immunophenotype comes back,
Mm,
is MCL or
yes.
something else.
Mm,
So that's why you just suggest, or you say most likely or likely or probable impression is.
okay.
You do not say complete that this is the blood film of CLL or MCL or follicular. You do not say like that in the exam.
Okay.
So, Masuma,
जी
so this is a GP refer blood film of a 35-year-old boy, man,
35.
35. The full blood count says hemoglobin is 140, white cell count is 11, and platelet count is 250.
Anybody can admit Romana because she's asking to admit. I cannot see her.
He has been admitted now.
Okay, Masuma?
जी जी
The BMS referred the blood film to you because he has found some abnormality in the blood film. So I will take you through the blood film, take a minute or two, and then report the blood film. Yes, now you can tell us your comments about the blood film.
So this is a blood film of a 35-year-old male which shows mainly neutrophilic leukocytosis and some toxic granulation in the neutrophils and with unremarkable RBC morphology and platelet count. Other than neutrophilia and toxic granulation, I couldn't appreciate anything.
These are eosinophils.
So I thought they might be, but I couldn't. I thought maybe this is a toxic granulation.
These are all eosinophils. There are no neutrophil in this blood film.
So these are dysplastic eosinophils then.
Okay. So report the blood film.
Okay. So a 35-year blood film shows mainly eosinophilia, which are dysplastic in morphology, and maybe some inclusions in RBC. I'm not sure about them. So what is this below this RBC? Whether it's
There's a platelet on the top of.
so there's only new eosinophilia and no parasites seen.
No. So the blood film shows.
Mhm.
Is there any stacking of RBCs on that?
I'm on thick side, that's why.
Sorry?
I'm on thick side of blood film. That's why
Yes.
there's thick.
Okay.
Yeah, so the blood
This
film
one is eosinophil, but the other ones which you showed before were neutrophils.
Dr. Mara, maybe initially I thought it was eosinophil, but
But this one is neutrophil.
No, you're all eosinophil.
I have seen a patient who had a similar type of eosinophils with all stages, and they were looking like a neutrophils. So I think
These,
these
okay,
are
EO.
eosinophils with all stages and with dysplasia.
so where you
I
have
think
find the myelocyte of the
cytoplasm-
eosinophil? I don't think there is any myelocyte. These are all I think they're dysplastic.
This one is
I didn't-
EO. Okay.
No, Sindhu is right. When you see like hypereosinophilic syndrome or any clonal sort of eosinophilia, you do see like different stages of eosinophils. I have seen also as well. The patient was hypereosinophilic with the organ involvement, and all stages of eosinophils are present.
Yes, but in this film, I
But
couldn't
I'm not
appreciate any
talking about this
myelocyte.
case. Yeah, not in this
So
case.
this one
But
is eosinophil, the other one is neutrophil. Eosinophils
No.
you can recognize very easily.
No, Dr. Amara, these are larger than neutrophils. Look at the size. And somewhat pinkish and
And the
granular.
granules are also not
Of the pink
neutrophilic granules.
that towards
Yeah.
yeah.
However, nucleus is dysplastic, so there is might
But the
not be left.
cytoplasm granules are in more favor of EO with more pinkish rather than
Neutral.
neutros.
Okay, Masuma.
Mhm.
You need to complete the report, blood film report.
So the main abnormality in this blood film is eosinophilia with abnormal granulation and nuclear lobulation with no parasites, normal looking with normal is in platelet count and unremarkable RBC findings.
What is this beside the new U?
Lympho.
Lympho.
Hmm.
So this is half of your blood film report. I need a complete blood film report.
You need complete blood film report.
Yes, this is a GP blood film.
Mm-hmm.
You have to say something to the GP what to do next.
So we can tell that this is eosinophilia and secondary
Yes.
causes of the
So we
eosinophilia.
can ask him to find out the cause, whether there is any recent travel history, any drug history, and any history of allergy, whether any signs, symptoms related to organ involvement, like the
No,
pulmonary,
Masuma,
the
you have
cardiac.
to in report you have to suggest for further
Secondary.
investigation. Yeah, in
Suggestion.
report you have to usually you suggest.
Secondary
Suggestion.
causes.
So, but I will root out the reactive and the clonal causes of eosinophilia.
No, but you have to write IgE for allergic or asthma or any allergic reactions. And then autoimmune you can address stool for
There is a
ova
long
and
list
egg.
of reactive causes. So
The important ones: stool for ova and egg, IgE level for allergic, then any autoimmune.
So in your report, you cannot write all of these things. You just have to write only one sentence. Please exclude reactive causes of eosinophilia. The GP knows what are the reactive causes of eosinophilia.
So I have to rule out the reactive and clonal causes, because just the reactive causes.
If you write clonal causes, I will give you 0 marks. How the GP can rule out clonal causes? You are the hematologist or GP is the hematologist?
Okay, GP. Okay. So for GP, you will write the reactive causes only.
Yeah. So what is the definition of clonal eosinophilia?
Clonal eosinophilia.
More than one persistent eosinophilia, more than absolute eosinophil count, more than 1.5, and it is persistent, I think, more than 6
For
months.
1 month.
1 month?
1 month.
Okay, new definition.
But that is hypereosinophilia.
Yeah, so you have to suggest as well to repeat the full blood count with blood thin after a month. If there is persistent eosinophilia, then you are thinking about a clonal cause. In this 1 month time, he would have excluded the reactive causes. Then is the role of hematology.
Do we advise them to deworm the patient or no? We just say rule out the reactive causes and repeat the CBC after 1 month.
Yes, we just say rule out the reactive causes, repeat the full blood count with a blood film after a month. If there is persistent eosinophilia, then you have to do your eosinophil panel.
Sorry, if there is persistent eosinophilia, then
you have to do a panel for clonal eosinophilia.
Dr. Amar, is there any cut of eosinophil count where we have to refer the patient to emergency as well?
That is the eosinophilic syndrome, when the patient has shortness of breath or chest discomfort and a full blood count shows very high eosinophil count, and there is no other cause for high eosinophil. Then this is the hypereosinophilia syndrome, and this is emergency. You have to give the patient steroids as soon as possible.
I think this emergency treatment depends on the features, clinical features or symptoms of the patient, along with if you find eosinophil count high.
Yes.
Dr. Ahmed, on microscope, are these eosinophil different in color?
They're all orange.
Just orange. Okay.
Yeah. So if no reactive cause is found, you have to send the blood for
Clonal cause.
what test you would do. This is a 3-mark question.
PDGFRA on by fish on peripheral, PDGFRB or FGFR1, even serum tryptase level as well.
2 marks. And third, you can do
You
both.
do then you do the target. You also ask for the molecular targets like JAK2 and BCR-ABL1.
You can send a peripheral blood for a fish. You can send, you can do bone marrow biopsy in the patient. And the third thing is if there is associated mastocytosis, you can send blood for serum tryptase levels. So this will be the complete eosinophilia question. We had a question in this exam, given high eosinophil count. They asked us to report the blood film, what question you would ask in a history regarding eosinophilia, and what next steps you would require you would do if there is no reactive cause found.
So which test you advised out of these?
All the three we mentioned, because it was a 3-mark question.
And in history, you asked about the travel history, drug history, and allergy history?
Yes. Medication history, travel history, allergic history, any systemic disease history, because eosinophilia can be a part of gastrointestinal syndrome, rheumatological syndrome, autoimmune diseases, or part of chest diseases or chest infection.
Thank you.
Then that would complete your answer. Now, a lot of the question in our exam were like this. They were not expecting diagnosis from us. They were just asking us regarding the approach, how we approach. So if a GP blood film is there, GP do not understand the hematology language, make things simple for him, and always advise them what to do next and give them a suggestion.
Okay.
So
Let's suppose, Dr. Amir, if this was a case of neutrophilia, so what would be your approach if it was GP and he have sent you this film with neutrophilia?
then again, a reactive causes for the neutrophilia. Is he any background diagnosis? If he is using any GCSF injections? If he has any infection or not? Because leukemoid reactions or neutrophilia can be because of infections, drugs, and if these things are out, then obviously malignancy.
If he asks you what next investigation would you advise? So in advice, you will say that I will rule out the reactive causes.
Yes,
If no cause,
history and the infection markers of the patient, plus a blood film. A blood film you are seeing already. If infection markers are not there, they are normal, and patient does not have any medication history, then you are suspecting that this may be a myeloproliferative disease, maybe a CNL, chronic neutrophilic leukemia. If it is only mature neutrophil.
thank you.
Okay, so how many we have done? I can see. So this is the last one. And we have got. Who is A?
Dr. Amir, Amara, I've done.
Then Tahir Rahman.
It's me, Dr. Sindhu.
Okay, you have a 60-year-old man with anemia
60?
and yes, with anemia and fatigue.
Anemia and
Fatigue. Anemia and fatigue.
okay. Okay, I got it.
Beautiful. It's beautiful picture.
Beautiful. Because I have done last 2 days before. That was
It's
my
really
patient.
beautiful picture.
If I'm not wrong. Yes.
Okay, start reporting the blood film.
Okay. This is the blood film of 60 years old, which presented with anemia and fatigue. Peripheral smear showed rouleau formation, secondary to the anemia, and these are normocytic normochromic. And platelet counts are normal. I can see the platelet counts in the background. And there is lymphoid cells, and these are intermediate size, and these having the bluish abundant cytoplasm with circumferential hair projection.
To me, they look like plasma cells.
They
Yeah,
look like
I'm
plasma.
also confused.
Yeah.
Is it the plasmacytoid
Yeah,
lymphocyte?
to me, it is a plasma cell with rouleau formation.
Yeah, to me it's also a plasmacytoid, or one or two look like plasma cell.
But there is a basophilic cytoplasm, but why there is flowy cytoplasm? Like, why there is a
See you
projection?
perinuclear HOF and perinuclear
Yes, I can.
clear
I can.
area.
Yes, perinuclear halo
Yeah.
is prominent.
Yeah. So
Ah,
it's a
yes,
plasma
yes,
cell.
yes.
To me, it's a
Plasma
plasma cell.
Initially one cell is look like
Hey.
yeah, in this case
This is like
Sindhu was confused, but there is a
yeah.
perinuclear halo, and the cytoplasm is not that much as as of a hairy cell.
But Dr. Shaheen, morphology is very deceiving
Yeah,
nowadays.
I know. Yeah,
So
I
it's
know.
not very much
In
important.
fact, on the high resolution, the cells become more clear, because on the low resolution, that looks like the hairy, but when
Hairy,
you
yeah.
barely look at them, there is the perinuclear hollow that you can see on the high resolution here.
But
The cytoplasm is wavy, as in this case, Sindhu was right. But there is a perinuclear halo is prominent in all cells.
yes, there is a halo around the nucleus.
Yeah, it's a
So
high resolution part.
if these plasma cells are present in peripheral blood, so I think it can be
leukemia.
plasma cell leukemia.
I asked you report
Only
the
findings. Okay. So these are plasmacytoid cells. These are intermediate to large in size, with eccentric nucleus and scanty amount of the basophilic cytoplasm with perinuclear halo surround the nucleus. And nuclear chromatin is somewhat condensed. Is there anything else which I have to add?
so 2 marks out of 5 marks. Again, I would say report the blood film. Features in the blood film, your impression, what to do next.
Suggestion.
No, I comment on the RBC and platelet and WBC, that these are
Okay. So most likely the blood film is consisted with
most likely
yes.
consistent with plasmacytoid cells. I mean, I can't.
Plasma cell
understand.
dyscrasia or plasma cell disorder.
Okay, plasma cell dyscrasia. Now, this patient needs what? What is your suggestion to do? What to do next? He has anemia. He has fatigue. He has plasma cells in the blood film. What to do next?
Then I have to check what is the cause of anemia and what is the hemoglobin level.
Into bone marrow, flow cytometry, your
flow.
fish, then your imaging.
No, first you write the serum protein electrophoresis immunofixation, and
In the
and
blood,
then
you commented on the cells. You're thinking most likely this is plasma cell dyscrasia. You are right. Urgent investigations are needed, like flow cytometry and bone marrow biopsy for this patient for confirmation of diagnosis. This completes your blood film.
So in blood in reporting, you are saying we have to advise our further investigation as well.
Yes, but not a big story, just the investigations which will make the diagnosis. So this patient has a lot of plasma cells in the peripheral blood. You have mentioned that the blood film shows multiple plasma cells with ruler formations and normal platelet count. Most likely, the film is consistent with plasma cell dyscrasia. To confirm the diagnosis, we need urgent flow on the blood and a bone marrow biopsy on this patient.
So similarly, Dr. Ahmed, if we are suspecting leukemia or some LPD, either we can say you can correlate with the immunophenotyping and the cytogenetic report, or we have to advise advise flow cytometry or cytogenetic for confirmation of diagnosis. Which line would be better?
This is a plasma cell leukemia patient. You cannot send a patient home. You have to admit him.
So you have to admit the patient, even in LPDs as well?
No, if they are asymptomatic, then you do not need to admit. They can be followed in a clinic as well. But if then yes.
But you don't know, no? Just a film came to you as referred by your BMS. So how would you know that the patient is symptomatic or no until and unless you go and see the patient and assess him or her?
So what we do normally, that if there is a leukocytosis or a normal blood film, if the patient is at home, we call them. How are you feeling? How are you today, sir?
But this is a practical thing. But what will you do in an exam scenario?
So in exam, if this is the blood film, then you would suggest this patient needs urgent investigations to confirm the diagnosis, like blood flow and bone marrow biopsy.
Okay,
Okay, so okay, thank you.
it means what we see on the blood film, and we have to advise further for the confirmation of diagnosis, right?
Yes, this would complete your blood film report.
Okay.
You
Normally
cannot,
we do like this, that we advise based on the suspicious.
you cannot leave blood film without suggestion. You would see a TTP case today, you just report it and then you leave it. No, you urgently contact the patient or find out where is the patient to see him yourself and assess him, because it is a hematological emergency.
Sorry, Dr. Amir, if it's a slide of TTP, so what will you advise in your reporting?
Yes, so
Urgent referral?
so this is most likely suggestive of a MAHA, like a TTP. TTP is a hematological emergency. This patient needs to be assessed urgently by the hematology doctors.
This thing you will advise on your report.
Yeah, so then you will write extra to make sure that you are a caring doctor. I will call by myself to the hematology doctor on call, because this
And
is
same with the APML.
yes, because this is hematology emergency. The things that you do in practical life, you will reflect it in your report as well. If you do not write these things, you would say this consultant is not caring. He
I have a
reported.
question, Dr. Amir. Sorry to interrupt you because I'm still stuck in that scenario. So when you say that that is my impression, it's a plasma cell dyscrasias, and then when you move toward our third option, that what is the suggestion? So when we talk about the plasma cell dyscrasias, then serum protein electrophoresis can we mention in because that comes in the screening for the plasma cell dyscrasias
No,
when we
you
talk
will
about
you will not you will not write plasma cell protein electrophoresis in the blood film report. If
okay.
they ask you a separate question, what investigations you would do further, then you will write this patient needs bone marrow biopsy, this patient needs protein electrophoresis, this patient needs imaging for any possible lytic lesions.
Okay, and in the suggestion, we will just add the marrow, anything else.
Nothing else.
Sorry, one thing, Dr. Amir, in APML report, you will write APML is a medical emergency.
Hematological
Start
emergency.
ATRA with TLS prophylaxis.
Yeah, so this is a hematological emergency, need to be assessed by the hematology registrar or consultant as soon as possible. You
Okay,
cannot
and same thing with TTP.
TTP as well. You cannot write these things and then keep the slide aside. No, you have to mention that I will inform them to inform my team about this case so that he can be assessed urgently.
But we are supposed to be hematologists, so why we write urgent referral to hematology?
No, you are just writing a report. Your colleagues may be in the ward, or your colleagues you are present in the lab. You are reporting the blood film
Yeah,
things.
I think Dr. Amir is referring
You-
towards the emergency. If you are
in-
not in emergency and you have to refer toward the emergency, then you need to refer towards some emergency registrar in hematology.
So if I'm on morphology rotation and I'm seeing the blood film, I cannot leave the morphology to go to that patient. I will call my colleague who is holding the on-call bleep and inform him that we have a patient whose blood film shows fragments, and I'm suspecting a TTP in this patient. Can you urgently assess that patient? then that hematology registrar will leave everything and will go to TTP patient
Okay.
or APML patient. Did you get my point or not?
Yes.
Yes.
Yeah.